Okay, we will start our conference today with our pediatric ground rounds. And our keynote speaker is Dr. Clifton Huang. Dr. Huang is a pediatric gastroenterologist from Cook Children's Hospital in Texas. He was born and raised in San Salvador, El Salvador, where he witnessed the country's long-standing civil war that damaged its healthcare and education infrastructure. This experience inspired him to become a doctor. Dr. Huang chose pediatrics because of his love for children and their innocence and resilience. Specifically, he enjoys gastroenterology because it often involves unique complex conditions with multiple organs that involves a hands-on approach to treatment. Dr. Huang's area of interest includes advanced endoscopy, procedures, endomicroscopy, pancreaticobiliary disorders, Crohn's disease, and colitis. Outside of medicine, Dr. Huang is physically active, enjoys spending time with family, trying new cuisines, and traveling. He's married to his greatest supporter and beautiful wife of 25 years, Nenny. She's not 25 years old. He's been married for 25 years. Nenny, and they have 3 children, Marco, Vale, and Victoria, as well as a Springer Spaniel. His name is Milo, and he is very, very cute. I met Dr. Huang probably 40-plus years ago. He was introduced to me by my mother. He actually was born first. He is, not just, our keynote speaker today. He's been, an inspiration to me and a standard to follow. And I've admired him all my life, and I'm just very proud to say that I've been able to try to follow his steps in many ways. And you'll see a lot of the things we are very similar. So please just let me introduce him.
Well, thank you very much, and good morning to everyone, and thank you for the kind introduction. And so within the next I'll try to do this maybe in 45 minutes. We'll go through this topic of pediatric gastroenterology advanced endoscopy. What are the new things that we're doing in 2024? Just a side note, we are a 480-bed children's hospital, roughly about a catch area of service of 2.8 million people. And disclosures were, my only disclosures, I have my brother Andrew here. You probably might know that he has some type of addiction to photobomb, so you have to be careful if you're trying to get you a picture. But he had some really interesting taste about getting in Halloween dressed like Dracula. But yeah, this picture was actually more than, almost 30 years ago. We're teenagers. We used to be in the rowing team together, and so that's Andy. So I'll cover the following objectives. We'll describe indications for endoscopic retrograde cholangiopancreatography in pediatrics, indications for EUS. We will talk about emerging technologies, confocal laser endomicroscopy, and we will discuss other interventional endoscopic procedures if we do have time. Advanced endoscopy is a term that is described to used for minimally invasive endoscopic procedures where we use the endoscope as primary tool. And this includes EUS, CRCP, enteroscopy, using different type of stents in different areas in the GI tract, doing all type of resections from mucosal to submucosal area. And given the rise of pediatric obesity, there is much more interest in bariatric endoscopy. ERCP has been a procedure considered in advanced endoscopy as the most difficult to learn in a sense because it has a lot of technical difficulty. We use side view scopes where we position ourselves in the right at the level of the papilla, and through the working channel of the scope, we pass sphincterotomes of different type of instrumentations. We use guide wires. They are our lifeline to do these procedures. In this case, we're doing a sphincterotomy right there, as you can see. It opens up the papilla more, and then through that guide wire, we pass different type of instruments as mentioned, like in this case will be a balloon, a catheter to extract this stone. Political lithiasis is probably the most common reason why we will be asked to do an ERCP. In a similar manner, we can actually access the pancreatic duct. And, Well, it's not running. So, but the pancreatic duct basically is a similar approach where we use a guide wire. First ERCP was described in 1968 by Japanese physician Shinya and a American physician McCune. First ERCP procedure in pediatrics was done in 1976, 6-kilo cholestatic baby, 3.5 months old. And it's important to know that the use of ERCP has moved from a diagnostic approach to a more therapeutic, given that we have a whole bunch of different instruments that we can pass through the working channel of an endoscope. We indicate ERCP for biliary causes and pancreatic at the common bile duct to remove any type of obstructions, to manage strictures that could be either congenital or acquired, to manage biliary leaks, for example, pancreatic leaks that could be caused because of trauma or surgical intervention, to improve drainage through the sphincterotomy. Rarely we see cancer. Pancreatic indications include biliary pancreatitis, recurrent pancreatitis, trauma, strictures, stones, leaks, and management of drainage and fluid collections. And so up to 2014, there was a big question about how safe it is to perform ERCP in children. And we came together, about 15 centers, and we did close to 1,100 ERCPs where we followed these kids prospectively. And interesting is to see that the rate of success for the procedure, including cannulation, sphincterotomy, were really high with minimal side effects. As you can see that the post-ERCP pancreatitis rate is about 5%, which is much lower than the adult data, which runs around 7 to 14%. We went further, and in our advanced endoscopy program and Endowed program, we created a couple IRBs, registries, to follow our patients that were getting ERCPs and endoscopic ultrasounds, and also some retrospective studies for confocal laser endomicroscopy, IBD and non-IBD conditions. And within our ERCP study, we saw that we did close to 203 cases in about 35 months. You can see that you can compare the population to the multi-center database. In Texas, we do have bigger kids. Everything is bigger in Texas. And the biliary indication is probably the most common indication to perform an ERCP in the sense of a cholecystolithiasis. But important to see cannulation, sphincterotomy. There were really good numbers, very comparable with the multi-center database. And our rate of post-ERCP pancreatitis being 5.1%, bleeding 0.51%, which is really good numbers. So overall, we can say that performing ERCP in pediatric patients is very safe and is very adequate. We also look onto predictors of prolonged fluoroscope exposure in pediatric patients, and we really look on to see the number of median seconds per ERCP procedures. Every time there is, we started with about 120 seconds per procedure average when we started our program. As we move on, our team became more expert in handling all these instrumentations. Now our average fluoroscopy time per ERCP procedure, 2023-2024, is about 42 seconds. So we did close to 203 cases, our youngest patient being 5 weeks, 5.4 kilos. Average mean weight is 65.16 kilos. We have 2-to-1 ratio. And the interesting thing is that we are seeing things like this. I mean, this is more like, it used to be more like a, procedure or findings that you would see more in adult patients where you have severe cholecystolithiasis. This is a 12-year-old female, 71 kilos, came with a one-day history of right upper quadrant pain, direct hyperbilirubinemia, elevated liver numbers, some of it fatty liver disease, of course. But as you can see here, I mean, we're trying to cannulate the papilla. There was a couple of stones blocking that area. And of course, this wire that is going through is trying to find its way completely all the way into the main bile duct. So once we have a wire there, we will pass this wire. And as you can see, everything that I would like to do within the bile duct that I don't have a view direct on my camera, it has to be with fluoroscopy. And you can see the amount of stones that this patient had. The next, this it's not really running well. Okay. So then what basically we ended up doing on this patient is that are you seeing image? Yeah, okay. What we ended up doing in this kid is we ended up performing a sphincterotomy, pulling out stone, but I cannot, for some reason, I just cannot forward the video. A wide sphincterotomy to pull out the stones. We ended up extracting maybe 2/3 of the stones from this patient, and then post extraction, we had to put a biliary stent because the papilla was extremely swollen. After it was treated, then we brought the kid about 2 months after. We removed the stent, we performed and removed the rest of the stones, and we ended up doing a cholangioscopy. So this is another technique that is being done now in our pediatric patients, where we are now putting a camera that goes through the working channel of a camera of our duodenoscope and gives us direct visualization of the bile duct. An indication for this will be to make sure that we don't leave a stone in this patient. I mean, if we have extracted, I think I remember maybe about 35 stones on this patient, we don't want to bring this kid again for another ERCP. I wish I could fast forward this image. You mean where? I get out of the presentation now. Are you okay? We go like this? Maybe it's. Yeah, you're right. So as you can see right there, all the amount of stones that are coming out. And so this is kind of like the interesting thing is that we're seeing this now in our pediatric population, and it's not uncommon to have, like a severe cholelithiasis like this. Thank you for the advice. And then, again, this kid ended up getting a biliary stent, and this is how the biliary stents look now. And this is another case of, this is a child that 15-year-old, not child, teenager, that had a CFTR, PRSS1 and D1270 mutation. Basically, this kid activates the pancreatic enzymes within the parenchyma before they are released and cause severe pancreatitis. As you can see here, this image right there, you can see that the bile duct is extremely dilated, maybe this mid to proximal, but really what is causing the dilation and the blockage of the biliary tree there is the swelling of the pancreatic head. And you can see once we cannulate the pancreatic duct, a very tortuous dilated pancreatic duct is there. This kid is managed with a dual stent placement. So we actually put a stent in the biliary duct, one in the pancreatic duct, and then these stents are left there for a couple months, maybe 2 months, and then removed. We have done ERCP also to evaluate patients that have traumatic liver events where they have a bile duct disruption. Usually these patients, when they have what we call a level 4 or 5 laceration, where you have at least 75% of the parenchyma destroyed with a lot of bleeding, then the bile leak usually occurs into the peritoneum area. And so what we have been doing with these patients is that we are doing an ERCP to try to correct or take care of this damage. In this case, as you see here, let's see if I can. Right here is the bifurcation. Oh, you're not seeing my image, right? Can you see my arrow? No, okay. So no, okay. So right there, that's your bifurcation. This kid that had a grade 4 liver laceration, you see the leakage is right parenchyma already. So that's kind of like the tricky part, is how do we go and then repair that area? Because even though after doing a percutaneous drain, it didn't resolve the problem. And so what we have to do is figure out and use different type of adult stents, right, long enough that could reach that area, leave it there for at least 2 months, 8 weeks after we'll remove the stent. And as you can see, this pressure cholangiogram, this lesion is completely resolved. We have done at least 10 kids, 7 of them were secondary to an abdominal trauma. We did 3 of these patients that had a bile duct injury after a cholecystectomy. And by doing this type of approach where you use the stents, this gets completely resolved. Here's another example of an 18-month-old, had a colocal cyst. They removed the lesion, and post-procedure, he had a massive bile leak. This is a 7 kilo. Technically, our duodenoscopes fit 10 kilos and above. But in this case, what had to be done was put a balloon to dilate both, here in the upper esophagus and dilate in the pylorus, then so that we could feed the duodenoscope, advance the duodenoscope, then cannulate, and then eventually leave a stent enough, and then 2 months after it's completely resolved. So definitely, ERCP with stenting coupled with percutaneous drainage is the mainstay of treatment for these major bile leaks in patients that have high-grade liver trauma. Endoscopic ultrasound is another mode. It is a procedure that was first introduced in 1980, Japan, US, and Germany. And it's a really neat procedure because it allows us to visualize sample lesions of the gastrointestinal tract and nearby organs, including pancreas, liver, posterior mediastinum, and retroperitoneum. So when we're talking about EUS, just think about your conventional abdominal, ultrasound, where you have a device that have a special type of crystal that gets excited with electricity. It sends a sound of beam, and then this returns back as an echo into the system, and then you have a computerized image, and then this produces either hyperechoic, hypoechoic, or anechoic type of images. We have different type of ultrasound equipment. We have what we call radial ultrasounds that give you a 360 scanning view. So it's kind of like perpendicular to your camera. And then you have linear ultrasound that allows us to have a front view type of approach, which allows us for therapeutics. And we also have mini probes that it can be passed through a working channel of 3.2 millimeters. So these are super tiny ultrasound devices that allows us to evaluate very narrowed areas. And just to give you an idea, and I think Andrew has this equipment, the Arieta 850, which is a really good endoscopic equipment. This is just an idea of how clear the images can be produced. Of course, this is just an example of an ultrasound radial scope that is in the stomach, is producing a 360 scanning view perpendicular to our camera. We have kidney, we have the splenic artery and vein, suprarenal gland over there. And as we are advancing this, we can really view outside organs that are not in the immediate vicinity of actually not in the GI tract. These are within the next neighbors to the GI tract. Adequate tests to evaluate the pancreas. And then as we are pushing this scope more into the small bowel second portion here at the duodenum, this technique allows us to evaluate the common bile duct, which is extremely important before doing an ERCP. We use vessels, our landmarks. This is the portal vein, portosplenic confluence, superior mesenteric vein. Here's the head of the pancreas, and here is the common bile duct. Why is it important? Because if we have an EUS equipment, we can always evaluate prior trying to do an ERCP. If there's no stone, then you basically are avoiding a procedure that has a higher risk for pancreatitis. And EUS is much more sensitive to evaluate for stone compared to abdominal ultrasound, regular abdominal ultrasound, or even an MRCP. Other indications to do pediatric EUS is like to evaluate subepithelial lesions. We can use it to evaluate the pancreas, chronic abdominal pain, and as I mentioned, indication for suspected cholelithiasis. It also allows us some type of intervention and diagnosis by obtaining biopsies, and we can use a linear scope in this position at the second portion of the duodenal bulb. We are accessing through the wall of the duodenum the liver. It's a very safe procedure, actually more safer than you doing it percutaneously, and you can get samples from different type of organs, including pancreas, liver, lymph nodes, etc., through this approach. This is another example of a child who 6 years old, I remember, who had a abdominal trauma. As you can probably see here, the pancreas is completely separated. A big table fell on her, on top of her abdomen, and separated the pancreatic duct completely. After a couple of months, she definitely developed a pancreatic pseudocyst, was large enough. We waited time for this wall to mature, and then we use our linear endoscope to position ourselves right kind of like at the stomach, body of the stomach, find the right spot there. And in this case, we have this device that has a ceramic tip, and we burn a hole through the stomach all the way into what we call the inside of the pseudocystic lesion. This lesion is not going to resolve by itself. You have to drain it, and this is the main approach by placing what we call a stent, which is a metallic, fully covered stent, and it has a shape like a dumbbell. So in other words, you have kind of like the larger phalange, which is deployed in this area inside the pseudocyst, and then you have the other part that is deployed within the stomach cavity. And as you can see here, we're going to deploy here in a little bit. You see that's one of the phalanges, and the next one is deployed. And as you can see here in this image, we will release the other portion in the stomach, and immediately this allows full drainage of pancreatic fluid. And she had like at least 400 mL drain at that point. And these patients feel immediately well. Eventually, after the procedure was done, obviously the pseudocyst decompressed the whole area. I did an ERCP, and you can see here is the ASU stent right there, and then cannulated both the pancreatic and the bile duct, and then left the stent, and this case had completely recovered. So the other important thing is that by trying to connect the pancreatic duct, then you basically save that distal portion of the pancreas that was separated. So we have been doing in our registry, following our patients with EUS, and we have done about 115 cases. These were captured between March 1st, 2023 to January 8, 2024. As you can see, there are a lot of indications to do EUS in our pediatric population. Most commonly it's done for cholelithiasis, but we are doing it for pancreatitis. We're doing it for liver biopsies. We're doing now rectal EUS to evaluate patients that have Crohn's disease, especially the ones that have very complex fistulas. Evaluate for masses, and so multiple things. And the important thing is that performing an EUS may also change our management plan. So in this case, out of 21 cases of patients that have cholelithiasis, we averted basically 4 cases that did not need an ERCP, so we did not perform, and then that means we avoid post-ERCP pancreatitis. We're also using EUS with elastography to evaluate patients that have eosinophilic esophagitis, and this is an interesting approach because when we are seeing the concern of possible fibrosis in the EUS, these are patients that are immediately started on dupilumab, and the post-observation endoscopic images show like a complete resolution of that potential fibrosis that we're suspecting by elastography. We're also using EUS on patients that have a primary anastomotic refractory stricture. Basically, these kids get redilated multiple times. We use the EUS to evaluate for the fibrotic band and then do endoscopic knife therapy, and I'll show you a couple images after. And that definitely improved, the outcome of these patients by not needing all these esophageal balloon dilations. We're using EUS to place lumen-opposing metallic stents, like the image that I just showed you a little while ago, and to evaluate for abdominal trauma, especially when you have a bile duct or pancreatic duct disruption. You can use the EUS to evaluate for the diameter of the eventual plastic stent that you'll have to insert in either the pancreatic or bile duct. Okay, let's talk about confocal laser endomicroscopy, because this is an emerging technology in our pediatric world nowadays. The word confocal comes from the Greek word homeostaikos, means an image technique that you basically use pinholes to eliminate out of focus light. It is a system where you have a illuminator and a detector with an objective lens. And so what happens is you apply fluorescein IB, it gets saturated in the extracellular matrix of the epithelium and the lamina propria, and then you shine a light, whatever rebounds back into the light and then passes through the pinhole. Anything that is out of focus gets removed, and then what you have basically is a image like this. So this is basically your live biopsy, kind of like histologic tool. You are seeing there images that are live of the villi, in a sense. The depth about 65 micrometers, so the depth of your hair. That's how deep the biopsy is. But the magnification is 1,000 times. So what you have here is a 30 plus time. This is 1,000 times. And what you want to notice here is you have the villi, you have a black rim there, like a, let me see if I can, right there. So here you have the epithelium of the villi, and right here in the middle you have all the blood cells moving around live. And then when this is pitch black, it tells you that there is an adequate barrier function there. We can, depends on how we put the probe, get images that are very similar to histologic findings. And the advantage of this technology is that it allows you to do target biopsies. You can sample broad, areas of the mucosa, and in real time you can differentiate between normal or abnormal, and then target your biopsies better. We have been using this in initial evaluations for GERD. What you're seeing here, one thing that the CLE would do is that it can evaluate the intrapapular capillary loops. Our interest is not too much on GERD, but does this offer a potential for eosinophilic esophagitis? The esophagus is extremely difficult to image with this technology because our endoscopes have a front view camera with a front view channel. And when you're in the esophagus, you kind of have to see on the side. But this is something that we're looking into. We all struggle with patients that have H. pylori. You probably start them on some type of therapy, maybe go to 1, 2 rounds, 3 rounds of antibiotics, and you cannot eradicate. Then you send these kids to pediatric GI to get biopsies for culture and sensitivity. You get biopsies and nothing grows. Well, this technology allows you to scan the tissue, find the colonies, get the biopsies, and if you find them, then it will grow, and then you can find the right antibiotic therapy. We're also using it for celiac disease. So that's another concern is we have patients that come to us, have really high serologic markers. You do the biopsies, and then it comes back negative. And then, well, this kid has celiac or not. And so what this allows you to do is look for areas where you will see more absence of villi or enlarged crypts, and then you kind of like scan it. And because celiac could be patchy, you have higher chances of finding where the condition is, get the biopsies, and then you have a positive sample. You have been using it for inflammatory bowel disease, and this is a really strong area of interest to me. As you can see here, your endomicroscopic images in this first group of pictures are on normal patients. You have the histologic finding, the CLE findings, and then you have the endoscopic finding here. As you can see, you can replicate a lot of the images there. A crypt with the vasculature around, no white in the center because it means that there is no leakage of the fluorescein out there. This is a villi with the blood cells around right there. And then we're seeing now, in this case, Crohn's disease. You have a villi where you have disruption of the barrier there. So the fluorescein that you are giving IB is now coming out from the tip of the villi there. And look at this crypt there, completely destroyed. It's normal to see like a number of crypts with an adequate distance around. When you are missing a crypt, means a destroyed crypt already. And this is a finding in ulcerative colitis. vascular tortuosity, increased cellularity. So what we have seen is that when we look onto the mucosal barrier dysfunction and we find epithelial gap density, fluorescein leakage, crypt architectural distortion, microvascular alterations, or increasing intracellular infiltrates, they are synonymous findings of active Crohn's or colitis. And these are actually findings that have statistical significance to diagnose an active or exacerbation of the condition. In pediatrics, it has been used to evaluate patients that have a risk of relapse by looking onto the epithelial gap density there, the space. So in other words, patients that have Crohn's where they had CLE performed and they found to have these while they were treated, that means that the higher risk of relapse was there. This is another important finding because we have a lot of endoscopic scores that technically in the clinical setting are not very practical. We don't probably use them as much. But the Rugert score was compared to what we call now a Watson score. And the Watson score is a mucosal barrier dysfunction system. And so what it's going to do here is compare, like in this setting here, you have what we call a Watson 1 image where you have the villi with a black, completely black surrounding, that's epithelium, and there is no leakage of fluorescein. So this is an intact barrier, and it's similar to a Rugert 01, pretty much. Once you start seeing some white background right there, it means that there is some fluorescein that is leaking from the epithelium all the way out into the lumen, and you have what we call more like a functional type of defect there. If you have now microerosions and this signal of the leakage is much higher, then you have what we call a structural type of damage. So these are compatible with active, disease activity. And why is this important? It's because as pediatric GI doctors, when we are dealing with patients with IBD, our goal is not just to clinically get them better. We want to endoscopically get them better. But we have also asked ourselves, is that the best type of remission that we should bring these kids on? And then keeping in mind that obtaining histologic remission in IBD patients is extremely difficult. We still have a really normal image, but then there is still activity, inflammatory activity in the biopsies. Well, what we call an endomicroscopic remission, basically where you restore the cell barrier, is very promising because, as you can see here, this is 4 different physicians that have reported this already. If you treat these patients and you repeat the endomicroscopic image and you go from a Watson 2-3 to a Watson 1, the outcome on these patients is much better in long term. It means that you have restored the barrier function, and these patients do much better clinically speaking. And this is an active research that we're doing right now is, should we move on to endomicroscopic remission moving forward on our patients? So how does CLE images look on our IBD patients? Well, first, I have to show you a normal patient. This is a patient that has normal colon. As you can see here, you have the crypts, vasculature around it, adequate intercrypt space. Now compare this to this image here where you have a lot of activity there. You have a white spot right in between the crypt, a lot of infiltrate of cells. You might have also absence of a crypt here, a destroyed crypt there. And so these are all findings that we're looking onto how to make the diagnosis at the endoscopy suite when we're doing our patient, evaluating our patients. And of course, these findings came positive histologically speaking. Another example is a patient with Crohn's disease, where you're seeing also a TI that is fairly inflamed over there. As you're seeing there, you can see, the villi. There is definitely some white background as well. And there is cell shading. So this is compatible with at least a Watson 3. This same patient that have Crohn's at the TI, look at the colonoscope. The mucosa overall is not really too concerning to me right there. But once I put the endomicroscope, I'm starting seeing now a lot of activity here as well. You can see a lot of cellularity. There is a white spot right there, so there is leakage of the fluorescein, and the tortuosity of the vascularity right there, you can see it's much more increased. So we are now in the process of putting together a histologic comparison between what the pathologists are seeing now under their microscopes, and then we are creating criteria to evaluate basically in the endoscopy suite, criteria to evaluate for endomicroscopic findings of ulcerative colitis. We have done, at least right now, we have reviewed 15 patients out of 43 that met criteria that had CLE images, and we found on them that, at least on them, when you have an intact barrier or a Watson 1, is histologically normal. And when you have a Watson 2 or 3, was compatible with a lot of activity. And so this allows us to create a new type of score. We're going to propose this very soon, where we are going to use what we call intra-crypt distances combined with fluorescein leakage, increased cellularity, architectural distortion to create a scoring system just like the Watson score for the terminal ileum, something now similar for the colon as well. So in general, we can say that at least CLE in pediatric IBD allows us to assess for the degree of inflammation, predict therapeutic response, relapses, predict disease behavior, and so on. But you may say, well, if you our pathologists here in Nebraska Children's, probably they can give you a pathology sample within 24, 48 hours. So it's not really a big deal to have a diagnosis right there at the endoscopy suite. It's not going to really delay too much the treatment approach. But I would like to really show you what would be the next step of this technology with inflammatory bowel disease. As you probably may know what this image is, it's just a very simple cartoon to explain how complex is the immunology in the gut. Think about what you're seeing here is an antigen-presenting cell, in this case a CD11 positive cell, dendritic cell that has active sensing or checking what is in the lumen. This cell interacts with a naive T cell. The communication between them, their language, are cytokines. They throw each other interleukins of different types. And depends on their interaction, this T cell that is naive becomes specialized. In other words, it will become a T regulatory cell, ideally, that proposes no inflammation at all. But if this naive T becomes a Th1 or 17, then you have Crohn's. If you have maybe the Th2 or the natural killer pathway, then you have UC. And all the drugs that we have right now to treat, like infliximab, basically what you're treating is the feedback of the T to the antigen-presenting cell that is producing a lot of TNF factor, and you are basically blocking this with infliximab, adalimumab, for example. But then you have all the new players now, like ustekinumab, an IL-12/23 blocker. You have mirikizumab, an IL-23 blocker alone. You also have vedolizumab, which is an alpha-4 beta-7 integrin blocker. And you have also the JAK inhibitors as well that is blocking at this level. So the question then comes to, what treatment should I use on my moderate to severe Crohn's or UC that I know I need to put on a type of biologic? And this is where I think the next step would be interesting to see where CLE will bring us, is that we have now created a kit where we are getting biopsies from ill mucosa, and these biopsies are put in different containers. Each container has a different monoclonal antibody, where we have attached a fluorescein to the Fc portion of the monoclonal antibody. Once the mucosa or the tissue biopsy gets attached to the FAB portion of the monoclonal antibody, we're using artificial intelligence to capture the amount of binding. So how much binding of this monoclonal antibody happens in this tissue. And then we want to come with a predictive score. So instead of saying, well, we're going to go first with infliximab because that's kind of like the first line and it doesn't work, we're going to move to ustekinumab. No, we're going to just try to find which one there is treatment for this individual patient has a better binding capacity and choose that one in a more precise treatment approach. We're also looking to do special proteomics in this. So that basically what tells you is what's the neighborhood inflammatory cell drive in that specific patient. So then what you are doing is individualizing therapy. And this is what is considered the gateway to molecular imaging. As you can see here, the future would be eventually to have a study or a technology where we can do this in vivo. So we have a model here, right, where we can look with a fluorescein, the endomicroscopic view, but also at the same time, a second wavelength and system to view the medication with a different type of fluorescein. And so what you're doing there is quantifying live what type of response there is on this type of, let's say, patient, right? But this is an animal model. So molecular imaging is definitely a growing biomedical discipline that enables the visualization, characterization, and quantification of biologic process that takes place in the cellular and subcellular level within intact living subjects. I don't know how I am with time. I mean, okay, still have a couple more. Okay. And so then this will bring us to the next generation of endoscopy, which we will use different type of technology to be more precise and then individualized therapy. I think I'm going to probably advance here, talk about food allergy sensitivity testing. This is something new. To my knowledge, there are only 2 centers in the whole U.S., pediatric centers, that are doing this. This is your center and our center. And what we're doing, and if you follow me, this is a group of patients that we have been studying. They all have chronic abdominal pain. They have like IBS type of symptoms. They come with changes in their bowel movement pattern. And these patients have a complaint. They think it's a food-related condition that is causing this. So on these patients, we all will perform a different test, and we make sure that they have a negative IgE, allergy test, skin prick test, celiac serology markers, fecal calprotectin, and then we obtain a food diary from them to identify maybe possible food allergens, and we eliminate 1 week to 2 weeks prior procedure the most allergenic foods, milk, soy, wheat, egg, peanut, seafood, and then we will perform an EGD with food allergy sensitivity test. How does this look? Well, we always do a control where we will look onto the mucosa and make sure that the mucosa is intact. Here you see, just remember this, epithelium, and it's completely black, no leakage. And what we will do after is we're going to apply the allergen into the tissue, wait for a couple minutes for it to react, and then we have a immediate reaction. And this is interesting because you remember this image here that was complete black. Now you can see how much white background is there. This is just within 2 to 3 minutes of applying an allergen. And we will say that one of the criteria for diagnosis is fluorescein leakage. So we're looking onto leakage of the fluorescein that was administered IV, as you can see here, coming out into the lumen. But you also need a second criteria for diagnosis, which is what we call these cell shedding. So the epithelium becomes widened, and then you start seeing epithelial cells right there shedding coming out of the villi. You have to have these 2 criteria to make diagnosis. The important thing is that there is definitely an adequate outcome. These patients actually respond really well. You remove the allergen that you find that is positive, they react to, and then the patients remain symptom-free. I want to talk to you quickly about a new method to manage refractory anastomotic esophageal strictures. These are patients that have a history of esophageal atresia. They develop a stricture right at the anastomotic site. They come to pediatric GI for endoscopic balloon dilations, and then that stricture narrows down again, and it's an ongoing process forever. When you have done this multiple times, we can say that it's refractory. And I had a patient that was sent to me because of a fistula, actually, a tracheoesophageal fistula. The reason why these fistulas are created is because when food hits the mucosa, it creates an inflammatory process. The normal response really is just to put a balloon and dilate and disrupt the mucosa. But what we are really needing to do is, on this type of short segment strictures, we're using a mini probe to evaluate for the layers where the fibrotic band is. And so then safely what we can do then moving forward is performing endoscopic knife therapy approach, where you cut and disrupt the fibrotic band at different type of levels. And eventually after doing that, you dilate the mucosa to a point that you don't end up disrupting just the normal tissue, but you disrupt also the fibrotic band. These patients don't need to come again for another esophageal balloon dilation, and this has been a game changer as well. And then probably this is also something that you guys are performing here. So this is a gastrostomy tube placement where we do a one-step. This technique allows us to use T-fasteners to bring the stomach all the way down up to where the mucosal wall is. Right at the center, we will put a dilation system device. We will measure the tract and then eventually put a gastrostomy tube there. The innovation here is that when you need a gastrojejunal tube, you usually have to have a gastrostomy first, allow it to fistulize well. At the meantime, the kid is on an ANJ tube for a while, but you don't have to do that anymore. You can use this same technique to pass a gastrojejunal tube from the beginning, and then you really solve this problem. So with that said, I think I probably would like to stop here. This is our team at Cook Children's, except for the doctors here, which these are from 2 different cities, but this is our, staff in Fort Worth in our main hospital. And I'm just really thankful to have a lot of people who support us, and this program has moved on really well because of all of that. It's really good to also know that all these procedures that I have shown you today, you have them here. So what is new is not too new to you guys because, Andy is already performing this. Any questions? I'm happy to take right now.
I do have one from the chat. Do you foresee this monoclonal ab tissue issue or ab tissue matching test to be one of use also in patients with GI grafts versus host disease in patients post-hematopoietic stem cell transplant?
I think that's a good question because the basis of the basic approach to understand what is the cause of the inflammation, it will be the same for, I think, all the GI conditions. In a sense, you will be able to test and find through CLE in this case and through spatial proteomics what is the specific problem on this patient. Because then what you're going to try to do is match the precision treatment approach. But we're doing it with IBD because it's a really, complex type of immunologic process. But eventually we will want to do this for this type of conditions for eosinophilic gastroenteritis. I would like to understand what is the pathophysiology in these food intolerances that we don't have. They are non-IgE, but we don't know. So understanding this type of approach will bring us there. Yeah, that maybe will become the standard of care. I don't know how long it's going to take us, but yeah. Mm-hmm.
Thank you very much for that really great presentation. I just wanted to have your point of view of how is pediatric endoscopy evolving over time. You've been practicing for some time, and you've seen some of the changes. And even though this type of procedures are not necessarily done, in every city or in every most states, you'll have someone, or at least in the vicinity of those states. But how do you see this evolution, and where do you think that this is taking us?
Well, I think that the fact that it's a minimally invasive approach, it is a must done, situation there. Endoscopic procedures are becoming much more therapeutic, and right now it's not unheard of, making holes between organs and doing things. I think that it's definitely going to grow more. It will allow us to decrease, for example, intra-hospital admissions. It will be less invasive with, large surgical type of procedures. I envision that in the future, most major pediatric GI hospitals will need an advanced endoscopist because we are also seeing that these procedures are safely done, under hands of people that are well trained, right? Safely done, and the outcomes are really good. And then on top of that, you see all the technology that is coming in. So it's really direct intervention to precision type of medicine that you are doing. And that's a really plus in general terms. Now, the other thing is also we need to have in the pediatric world, the pediatric advanced endoscopist is doing a lot of things, whereas when you go to the adult world, whoever does bariatric endoscopy is not necessarily doing pancreaticobiliary, right? So, or for example, they are not doing enteroscopies or resections and things like that. So I think at some point, if the number allows us, it will also permit us to grow into the subspecialty areas too. But there is a lot of exciting, situations and things coming up for peds, and pediatric endoscopy is rising up, and we are getting our own numbers, our own data sets for outcomes, and so this is going to, just grow more and more, to be honest. On the other hand, financially good too, because procedures do bring a really good amount of revenue to these hospitals. So it's a good thing to, support. Yeah.
I did have one question.
Mm-hmm.
I was most excited about the data on IBD and CLE that you presented. I wanted to ask you, in your practice, insurance ties our hands a lot when it comes to pediatrics and IBD medication specifically. How do you with this data that you have, or some of the findings that you find, especially under kids under 18, when a lot of medications are not FDA approved, so you have to try the conventional ones first, how you sort of navigate that?
So that's a really good point, because, the reality CLE, we are having a hard time. It's not 100% cover. That's one thing. So that means that whenever I do CLE, there are just certain insurance carriers that will allow this to happen. I got to manage a lot of our very complex IBD stuff, because before doing advanced procedure, that was actually my area of expertise, is inflammatory bowel disease. And I was able to establish relationships with already the insurance peer-to-peer directors. So they already know me, but it has taken at least 4 years. So when I have a complex kid and we do a peer-to-peer, it's not too difficult to me anymore to navigate that route and get it approved. But it is something that the ideal situation is you have to have one or two of your staff to be dedicated. We call them IBDologists, right? And then you have to establish your reputation as these type of cases that you are doing. And then you have to come just with all the proof. In a sense, moderate to severe Crohn's that have, let's say, fistulizing perineal disease. I'm not going to waste my time on an immunomodulator. We are not doing that anymore. So we're going to start probably 10 per kilo of infliximab. Now, that's going to trigger the peer-to-peer. But then you are ready, because we already have data to publish, to back up that. So I think being very proactive and then showing, allows us to get a better response.
In what sense do you see that the future of, speeding up the process of FDA approval for these drugs to pediatrics, knowing that we have a way to prove the affinity, or we will have a way to prove the affinity of the drugs to each patient?
Yes, I think that's a good point, because the natural trend is this. You get a drug that is exposed to the adult world. Uh-huh. It gets to work fine. And then it comes to our world maybe 7 years after, right? And that's when the FDA starts triggering in there. But I think what we have to do is we have to publish, and we also have people that have to sit in our endoscopy meetings, our North American Society of Pediatric GI meetings that advocate a lot for this type of, procedure. That's the only way that we can, increase the speed of this type of situation.
It was really great, your presentation. I really enjoyed it, and really taking us to not only to the present but the future. I have just a technical questions about those challenges that you were doing. Were those patients EOEs that you were doing in the duodenum, or those are eosinophilic gastroenteritis patients?
To see those? None of them. These are patients that basically had food intolerances, that they didn't have a diagnosis, but they were IgE in blood or skin prick test negative, celiac negative, calprotectin negative. So the response that you're seeing there is a non-IgE response. Now, that's a good point that you bring, because now some collaboration that we would like to have between hospitals is, can we look onto a group of patients that have eosinophilic or eosinophilic gastroenteritis? How is this working? And just as a kind of like a really small comment, maybe you have seen collagenous gastritis as a condition. Some of our patients where we have been doing CLE by removing the wheat, they have a positive CLE to wheat, but they have a negative IgE to wheat, and the collagenous gastritis disappears. And so there's a lot of new stuff here, but these patients are diseased. They don't have EOE or
no GI manifestation.
No, that's right. That's right.
There's currently a study unpublished from a German physician who is doing CLE and doing food allergy challenges in the duodenum and the guiding therapy for eosinophilic esophagitis. We still have to see the data behind it, but
that's what I was wondering also. Yeah, exactly. If you could just do it and then the surrogate of what may be happening.
That's right. So then the question for EOE would be, should we try this directly in the esophagus, right? Yeah. But I think we have to first answer the question of getting adequate esophageal images, because it's been a really big challenge to all of us.
Even using the side view of the RCP.
Yeah, but it's just that it's big, and it might just break that probe. So maybe what it needs is we need a side probe. They have to make a probe that ideally would come, with a side focus rather than front, through a regular scope. Perfect.
Well, thank you, Dr. Huang, for that very wonderful presentation and for sharing your expertise with us. And now most people will understand why I look up to him, so much, right? If you have any questions for Dr. Huang, you can post them, and we can always address them at the end as well. And all right, so for those who join us today for Grand Rounds, a lot of them already have left, but you're free to leave the room and make sure that you use 32420. Okay. All right, and we can try to move on to the next presentation.
Yeah, we'll pull up here.
Thank you.
I'll let you. I'll let you go first, Aaron.
Okay.
Okay, well, thanks again, Clifton. There was a great presentation. Now we'll continue. We are going from one to one. Dr. Juan Pacheco, Okay, well, we are going to start or continue our conference. We are going to have our first out of three presentations. The first one is going to be about chronic recurrent pediatric pancreatitis and associated procedures. Andrew Wan and Steve Romans are going to be presenting this. Dr. Juan graduated from the La Universidad Dr. José Matías Delgado in El Salvador in 2008. He then went on to complete his general pediatrics training at Nicklaus Children's Hospital in Miami, Florida. Andrew pursued some further training here at pediatric GI at the University of Nebraska Medical Center and Children's Nebraska. And he did advanced procedures, endoscopy in Guayaquil, Ecuador, and Montreal, Canada.
Dr. Huang leads our pancreatic disease department, our advanced procedure services as well, and also is serve our community with a multidisciplinary pancreatic disease clinic. We're also going to have Steve Robbins. Steve comes to us with 15 years of nursing and scrub experience in surgery and cath lab combined, 2.5 years as charge nurse in surgery, current service lead supervisor for our GI labs, some brand new rooms that we have in the operating room. Please join me to welcoming our presenters.
All right, thank you very much. And I'll call Steve here in a little bit so that he can join us to talk more about our joint participation in endoscopy. So first of all, I'll just go through some concepts regarding chronic pancreatitis in pediatric patients. I don't have any disclosures, and our objectives mainly are to define, what is chronic and recurrent pancreatitis, its causes and its prognosis, as well as procedures that are associated to this and the role as a team with our nurses and our techs. Okay. First of all, chronic pancreatitis or recurrent pancreatitis, it is defined as an inflammatory condition that generally will have consequences that will probably change the course of the health of the pancreas. And generally, acute pancreatitis is seen as a single event, and chronic pancreatitis is seen more of as a process that happens. Right? More than 2 attacks of acute pancreatitis, can be seen as recurrent pancreatitis, and as well as this can happen in chronic pancreatitis as well. Okay. So histologically, we understand that there is going to be changes in the tissue and the parenchyma of the pancreas, and patients will develop scar tissue, which we histologically know as fibrosis, and there will be loss of functional cells of the pancreas, or acinar cell loss. And how does this interaction look like in our endoscopy room? So,
well, thanks for having me. I picked this picture, the ideal endoscopist, because Andrew, other Dr. Huang, they only have 2 arms. Sorry, I'm not a public speaker.
Yeah.
Bear with me. All right. Yeah. So they rely heavily on their assistant, whether their assistant, however your setup is at your institution, whether it's a fellow, or here we use nursing surgical techs. So this is a team sport. Any of these procedures cannot be done without this group of people. So we've got the endoscopist. A lot of times we have a fellow or a resident here. We're a teaching hospital. Anesthesia staff. We have the nurse and the scrub, which can be a nurse or a surgical tech. You remove one of those people, the procedure can't be done. Okay. So, and Dr. Huang, Southern Dr. Huang, I don't know how we're going to, this was a mess, but OG Dr. Huang, I don't know. So he said something in his presentation that stood out to me. And a lot of it was like way over my head. I'm a C student, right? So luckily a lot of you guys understand it. But, he said as his team got more familiar with his cases, the radiation times went down. Procedural efficiencies greatly increase your outcomes and greatly decrease your adverse events. You're pumping. Oh, sorry, but you're pumping radiation into these kids during these procedures. The less radiation you can use, the less of an adverse outcome you're going to have from that. The more efficient you become, the less anesthesia you're giving the patient for the same procedure. And these things that Dr. Huang presented and Dr. Huang is talking about also, these are tools. Our endoscopy scopes are tools. The ERCP, they're all just tools, and a hammer is only as good as the carpenter holding it. And luckily we have talented carpenters here.
Right. So just if you look at this room, looks pretty busy here, right? You have a fluoroscope, you have an endoscopist, you have a tech or a nurse that looks like a pediatric patient here, and there's maybe an anesthesiologist here, and there's someone else in the back here. So multiple screens, right? And everyone's wearing lead, and there are computers, there are screens everywhere. This is our typical interventional room, and if you see, just like Steve perfectly described it, you can't really do this by just one person. This is a multiple a limb procedure, multiple player procedure. So ERCP stands for endoscopic retrograde cholangiopancreatography, and it's a very, very fancy way of saying we get into some very tiny ducts, right? And this is our equipment, and the room is full of different devices like this, and we have they're very sophisticated in the sense that they're flexible. This specifically is an endoscopic ultrasound, and has a probe right here that has a crystal that Dr. The other Huang was talking about, and he so we are able to put in this right next to the tissue, and we're able to reproduce images by the form of sound waves being collected by and processed through a computer, and we're able to reproduce these images that are letting us see just beyond the mucosal surface of the GI tract, right? And these are some of the devices. This is a sphincterotome that is preloaded with a wire, and this helps us be able to access the bile ducts. And this is a stone extraction balloon, but at the same time, it helps us make either a pancreatogram or a cholangiogram. And we have a shelf full of different devices that we use to be able to access these areas. And we also use sophisticated coagulation and cauterization machines for this procedure. We need X-ray as well, fluoroscopy, and then we need a team, right? Like what we were saying. And this is Brenda, one of our most awesome nurses, very experienced, and she's always there to help out along with some of our other nurses. And you can see this is the endoscopist right here to the left side, and there's a very intricate interaction between the nurse and the endoscopist. There's constant communication, and if you can see, there are two screens here, and if you notice here, we're actually getting into the pancreatic duct right here. So it's a difficult procedure, as Dr. Huang said. It's probably one of the most complicated endoscopic procedures, and I always describe it as you're trying to get in through a small pinhole or a door that has two other doors that are about 1 millimeter each in opening at the beginning, and then they open up to 3 and 5 millimeters or 4, and but you can't really see where you're going other than with fluoroscopy. So it's very complicated. Our wires are the length of or the width of 0.035 of an inch, 0.025 of an inch, and 0.018 of an inch. So they're just about the width of a hair. Okay. So all right. So what causes a pancreatitis or recurrent pancreatitis? Biliary disease, right? You can see here an ultrasound, endoscopic ultrasound, and there is a stone there. We removed that stone. There's pancreatic strictures. You have more strictures here in this MRI. We were able to access here. So when I was doing this procedure, we were able to do a pancreatogram. Steve helped me pass a balloon, and we dilated the stricture. Then we placed a long pancreatic duct stent. You can see it right there. And then you had this, we did a cholangiogram as well to make sure that the biliary system was healthy. Now, in other times, if this pancreatic duct stricture was a ongoing problem, this would have resulted in a Pusto procedure. Right.
So unlike other surgeries, the assistant, which is a nurse or a scrub, is very active in the procedures. I joke around with him like, you're going to go tell the family you placed a stent, but you just held the tube there. You know, I placed the stent.
Yeah.
Like, he has to have a lot of trust that I'm going to do what it is he wants me to do when I want to do it, and that goes back to that communication and that trust. And like he was saying, his radiation times are going down as his team, like that relationship was built. As his team got better with him, the whole team got better, outcomes went up.
You know, something that that I've always had with Steve, Brenda, Maria, and Grace, you know, our nurses, they're when I'm always talking to them, and as I am, you know, for example, if I'm pushing a catheter, they're looking at my hands. They're not necessarily always looking at the screen. They're looking at my movements. They're always kind of asking this, for feedback of what we're doing at the moment live, right? As this is a very complex procedure, we just have to have very good communication, and we also have to communicate with the fluoroscopy tech and ask the fluoroscopy tech to find the right image for us as we're doing this through the procedure. And sometimes the endoscopies, even though I'm pushing the wire, I'm so focused on doing that, and Steve has many times suggested, why don't we try this different thing, and that actually does work. And this is, again, a procedure that is done by a team, right? So this is our EUS tower, and we use this to produce those images. And here we have one of our fellows training for the placement of the lumina-posing metal stent, which is that stent that Dr. Huang mentioned about, that is called an axial stent. And what you do, and I'll show you guys some pictures here. So what you do is we go into this pancreatic necrotic tissue that is encapsulated, and that we basically poke a hole through the stomach, and then put this double, a lumina-posing metal stent that has a lumen inside, right? So we are draining it, and then we're able to, get pancreatic necrotic tissue out. And this is typically followed by something like this called a necrosectomy. And here we were able to go in through this stent into the cavity where the necrotic tissue was, and be able to clear and clean up all that stuff out, and the tissue looks significantly better afterwards. And you can see this is the pancreatic wall-off necrosis. This is stomach, and into the this is now a collapsed wall-off necrosis right here. So this is another example of wall-off necrosis. And this here is a disconnected pancreatic duct syndrome example. Right, you can see we were able to get into the pancreatic duct right here, and some contrast. There's contrast right here, and if you notice, this doesn't follow the normal anatomy like a duct should look like. So the pancreatic duct disconnects somewhere around here. This case gave me a little bit of a headache, as there was a stricture down here. We ended up dilating the stricture, and we ended up putting a pancreatic duct stent so we can salvage that pancreas. This patient had developed probably loss of a good, I would say, like 85% of his pancreas from medications. All right, so that's the conclusion of our presentation. Are there any questions that we can answer right now?
Okay, well, I want to thank both of the presenters. When you hear them talking, you think that they have been doing this for years and years. And just to keep things in perspective, Dr. Huang, you started doing this procedures a little bit less than a year ago, I think, for ERCPs, US 6 months. And okay, I dropped the mic. We haven't finished yet. All right. go. But what I want to point out also is like Steve has been with us, as I say, for a long time, working in a CAD lab, and I think his expertise is really bringing up to speed really fast. I think the things that he did in the CAD lab help us to do this. I don't know if there's any questions in the chat for them.
There's not yet.
Okay, I will ask you, Andrew. What are the next things that you think that you want to kind of develop here as an advanced procedure? Some of the things that probably you are not doing quite right now. I think we have talked about some of those, but I would like you to share those things a little bit.
Yep. Yes. That's as the field of should I?
Yeah, please. Probably close to the mic.
Yeah. I guess as the field of pediatric advanced endoscopy, evolves and develops, I think here what we're aiming for is to be able to maybe start looking into bariatric endoscopy and also POEM, which is what we call third space endoscopy. And POEM is a procedure called peroral endoscopic myotomy, and it's an alternative to the Heller's myotomy. Now, there are at least 2 or 3 papers that have, talked about the safety and the efficacy of POEM in pediatric patients, and it's actually a very popular alternative to the Heller's myotomy in adult achalasia. Now, I think that it's even bariatric endoscopy as well, like POEM. They're not there to replace the surgical procedures. They're there to be an alternative to them, as there are different patients with different needs. Now, those two are some of the procedures that I would definitely look into, moving forward within the next year or two, and then also trying to work on the improvement of the use of these current technologies, like CLE, and as well as technologies that we have available to us that are underutilized. I have this somewhat utopic idea that a lot of, like, for example, CLE should be used as a diagnostic tool for by most gastroenterologists, or I think I envision that in the future it will be like that. It will be like taking biopsies, right? Or certain aspects of endoscopic ultrasound should be used by a lot of gastroenterologists. So looking into the development of training, right? Training more gastroenterologists to be able to do these procedures is also one of our goals here at this center. And and then as well as collaborating, we're really blessed to have collaborators like Dr. Huang and other centers as well that are very open to be able to push the field, right? So collaborating and getting data, our own data, to be able to reflect how useful or how safe or how effective these procedures can be in patients, and again giving this data to help minimize risk, minimize complications in patients.
Yeah, the other thing that we have noticed, obviously, as you start doing this, that all of a sudden we have the increase of these procedures, and we have talked about that before. But what was happening with these patients before we were able to do this? Obviously, we were referring some of them to ERCP done by adults or other advanced procedures, but there were some others that we have been able to minimize minimally invasive approach to this. Could you make some comments?
That's right. I think some of these patients would have just followed their natural course of their disease. If those strictures they go untreated, they will eventually develop more episodes of pancreatitis and earlier loss of pancreatic tissue. and end up in a pusto or end up developing pancreatic insufficiency a lot earlier. That's one example. The other situation that we're seeing, that we notice, is that a lot of these patients were never actually coming to us. They were just going straight to an adult gastroenterologist. As this became available, they're being funneled to us from the region and from the even from the adult hospitals. They're referring these patients to us. If it's a teenager, I don't think that it's too different from an adult, but certainly adult advanced endoscopists, they typically don't like to do an endoscopy on a 3-year-old that weighs 20 kilograms. So this is why we have this. They're well able to. It's just it's a different type of patient for them, right? So, but that's why we have our center here, and our hope is to be able to continue to serve the community with these procedures and be able to develop and establish a center of excellence for endoscopy, doing this type of cases.
Any question on the?
I have a question.
Yeah.
So maybe you can comment, Andrea, in the fact that the reality is that for pediatric cases compared to adult, our volume is much lower, and I do envision the same type of situation where you have more of our GI endoscopies being able to do more procedures. How do you think we can break that barrier? In the sense of we need to train people, but what are the strategies that we could do?
Yeah. So there'll be a number of cases per center, right? So that's a limitation, right? We can't make patients have more disease, right? So I think that, or more patients have the same disease, right? So I think that being able to have a multi-center training approach would be a very, very beneficial thing, where you have a couple of key centers in the country where they're higher volume, just because maybe they're the only centers in the vicinity of those states that have the service, and if endoscopists are able to have some very well strategized rotations in these centers, say a month in a place, a month in the other place, and a month in a different place, and they have different learning strategies from different endoscopists. And I remember, being a fellow and learning some things from Dr. Quiros and learning some things from another 3 or 4 physicians, and I kind of took the best out of what I thought it was from each, and putting things together and made my own technique. So it's especially in advanced endoscopy, I think it's best if you're trained by several people rather than just one, right? Unfortunately, we don't have several advanced endoscopists in each center, so the way you cross that bridge is by creating some sort of multi-center training approach. Again, very utopic, right? It's maybe difficult to coordinate, but I think it's not impossible. I think it's very possible, especially if you have a good structure and the willingness of and the kindness of doctors that are, hoping to be able to push the science this way.
We do have one quick question in the chat. Are these procedures being done at Nebraska Med Center or just here at Children's?
They're both. They're done at both places. Though here is where we do pediatric cases. We have not started doing them at the Med Center. We've actually had referrals from the Med Center for this procedure, but I do have ERCP privileges for the Med Center. So the adult advanced endoscopy group will do it for adult patients over there. So the answer is yes. The procedures are being done in both places, here for pediatric patients and over there generally adult patients. All right.